exhaustive method. You go reverse clinical medicine. First, you get all the tests, and depending upon the test, you start further investigation. But what we will advocate is what is called a hypothetico-deductive method, where we analyze individual things and so that we can rationalize on our investigations and also cut the cost for our patient. But there are two major problems in this, what are called heuristics and what is called cognitive disposition to respond. These two are the terms used by cognitive psychologists, because nowadays clinical medicine is being analyzed by psychologists and they try to find out what are the errors which clinicians make based on heuristics and cognitive disposition to respond. I will discuss in detail about them subsequently. So usually what we do is a clinical problem can be assessed by two ways. One is a top-down processing, just like what I initially showed you. History, chief clinical findings, then test, and then go forward. Most of the time nowadays we do what is called a bottom-up processing, where we already have the data. Many data are already available because the patient has been referred from some other hospital. You have a bunch of test reports available, and from bottom-up processing to try to find out what are the various causes that could have given rise to these data and try to arrive at a decision. Here we have a break. This is a bottom-up data. So this is a patient who is a 50-year-old male. These are the data given to you. So what is striking in this? The fasting sugar 599 and the PP is 720. In fact, this was a WhatsApp message sent to me by one of my friends just a week ago, and then he had sent other reports also in the same patient. Initially, he didn't give any history. So most of the time as consultants, we face such situations where we have to do bottom-up processing, where the hemoglobin was 10.8, TLC okay, ESR slightly high, urea 59, creatinine 1.2, and sodium 128, potassium 6, and chloride 103. This is a 50-year-old male, no history given. Now you have to ask for history and other examination findings. So what exactly runs through your mind from a bottom-up reasoning? Trainees? Same patient, I had shown the sugars earlier. 50-year-old male, fasting 599, PP 720, and sodium 128, potassium 6, urea slightly high, creatinine borderline. What exactly is going through in your mind?
Pseudohyponatremia.
Whether you want to call it pseudohyponatremia or something else. What is pseudohyponatremia and what type of hyponatremia this is? Yes, you are on the right lines. So you want to do some correction for arriving at real sodium value. So how do you do the correction?
For every 100 mg per dl, we add 1.6 milliequivalents of correction factor for the sodium.
So in that, this patient is almost 600. So 500. So 1.6, some people say 1.8 is one that which said 2.4 also. There is a lot of error in this. There is a recent article which has even debated on the correction factors to be used. So even then, even if you use 1.6, 5 into 1.6, 8. So 128 plus 8, 136. So the sodium is normal. So what type of hyponatremia it is? Yes? Translocational hyponatremia. Correct. So this is not clinically significant because there is no hypotonic hyponatremia. This is a hypertonic hyponatremia. The patient is having actually a hyperosmolar state. So what else? Why the potassium is high? If the lab report is correct, if it's not a hemolyzed sample, Then you have to ask the history. So what all history you would like to ask? Now my friend writes, this patient, 50-year-old male, is admitted with a stroke, left hemiplegia. He is a known hypertensive and diabetic, already on several treatments, and also a known case of ischemic heart disease. Medications, most important. This patient was on telmisartan.
Yes.
But if you don't have history of medication, normal, no ACE inhibitors or ARBs, in a diabetic patient, 15 years duration of diabetes, if you get such a picture, what is your diagnosis?
RTA
Type 4 RTA, hyporeninemic hypoaldosteronism. Or you want to see whether it is Addison's, because low sodium, but low sodium we already have found out that it is not actually low, it is a. So with just one page of lab values, your mind can go in different directions and you try to deduce several hypotheses and finally arrive at a conclusion. So that is what is important. Whenever you get one paper, one lab value, just treat every report based on your assessment, your analysis of the clinical situation, and in this patient this was most important. So clinicians' thought process, if you analyze, there are two major ways by which we analyze cases. Both these have been illustrated beautifully by these two great books. One is Blink by Malcolm Gladwell and the other is Thinking Fast and Slow by Daniel Kahneman. If you have time, you should read both these books. In Blink, this is not for doctors. In Blink, what he says is your initial impression many times is the correct impression, because we tend to make some initial impressions, and as far as physicians are concerned, this is pattern recognition, or what is called an instant hunch diagnosis, and in German it's called Augenblick diagnosis. Many specialties are amenable to blink diagnosis, like for instance in our specialty, in acromegaly you can diagnose from a distance, Cushing's, and many senior professors are very fond of making blink diagnosis. One of my neurology heads, whenever we used to take any patient to his room, from the distance he will say, "Why Rogdor? No need of bringing in Parkinson." Later it may turn out that it is some lumbar radiculopathy, because of that the patient is walking like that. But he was very fond of making such diagnosis. So there are pros and cons of both the approaches. So as clinicians, we rely on both this. Many times in emergency, pattern recognition and blink diagnosis, and then systematic analysis, both to and fro we keep doing. This is actually a beautiful paper where they gave these in neurology what all diagnoses are possible by Augenblick diagnosis. This is from a German, this term is German, but this is a publication from seminars in neurology. Then clinicians use what are called heuristics. Heuristics are simple, efficient rules which people often use to form judgments and make decisions. These are actually called mental shortcuts that usually involve focusing on one aspect of a complex problem and ignoring others. These are usually handed down from the seniors to the juniors. The common heuristics in clinical practice are, if it looks like a duck, sounds like a duck, and walks like a duck, it's a duck. Common conditions occur commonly, including their atypical variants. If you hear hoofbeats, don't think zebras, think of horses. Look for a single diagnosis that can explain all the findings. This is what is called Occam razor, which I showed you earlier. And most of the time we follow Occam razor whenever we analyze any clinical problem. I will subsequently illustrate with examples. Favor a diagnosis or choose diagnostic investigations that explains the clinical findings or are most likely to verify the diagnosis, to go where the money is. That is called Sutton's law. This is a very humorous application of the name of Sutton. Sutton was actually a bank robber, and when he was arrested and the judge was pronouncing judgment, he asked him, "Why are you robbing banks?" He said, "Because that's where the money is." So Sutton's law means go where the money is. try to investigate for some diagnosis where all the possibilities or all the investigations are possibly pointing to that diagnosis. Then in therapeutics we have some heuristics. First, do no harm. The best medicine may be to do nothing, treat the patient, not the numbers. These are all good heuristics which are handed to us generation after generation. Whether it's a duck or a goose, or finding zebra amidst horses. In endocrinology, it's very important. In every specialty it is. It is a tricky proposition. Expertise in a narrow focused area, you may think that every hoofbeat is a zebra. One of my professors who was a specialist in vaginal granulomatosis, any cavitary lung lesion he will suspect vaginal, even though we all used to say it may be tuberculosis. Because if all you have is a hammer, everything looks like a nail. The converse is also true. Avoidance of uncommon diagnosis. This is called zebra retreat. That many times when we are unsure, we have not seen a particular diagnosis in our past experience, and that diagnosis is very difficult to confirm with the available tests you have in your hospital, you try to avoid thinking about that diagnosis. This is also one of the cognitive mistakes we do. Occam razor is what is called lex parsimoniae in Latin, which means law of parsimony. Parsimony means thrift or spending less. This is a problem solving principle. Actually, it was not initially in medicine, but he was a theologist, William of Occam, who was an English friar and scholastic philosopher and theologian, who first proposed that among competing hypotheses, the one with the fewest assumptions should be selected. In clinical medicine, it is parsimony in diagnosis. That is, you try to explain the patient's symptoms and signs, everything under one umbrella, under one diagnosis. For instance, in a patient of congestive cardiac failure, if there is jaundice, you try to think of congestive hepatopathy, not viral hepatitis. Post-operative fever, you will try to think of a surgical site infection or UTI because of a catheter, not leptospirosis or malaria. But there are people who speak against this also, that what prevents a patient from having 2 diseases or 3 diseases. This is just for a humorous counter to Occam's reason. This is called Occam's law. So now we'll start with cases. MM is a 38-year-old businessman, was detected to have diabetes 1 year ago while on investigation for difficulty in climbing stairs, getting up from squatting, numbness and paresthesia. He was treated by a neurologist as diabetic neuropathy and amyotrophy. Family history of diabetes in father, weight 88, height 178, BMI overweight. Initial fasting was 180, postprandial 245. He was given glycoside plus metformin 1 TID by a physician. For the last 6 months, multiple somatic symptoms, constipation followed by intermittent diarrhea, depression and insomnia, seen by a psychiatrist and prescribed amitriptyline. Lost 18 kilos weight due to anorexia and diarrhea. Seen by a gastroenterologist, barium will follow through normal, endoscopy, non-specific gastritis, duodenitis, treated symptomatically. Pruritic skin lesions on abdomen, inner aspect of thighs and discoloration of nails, treated with topical creams with no relief. Injection of multiple over-the-counter medications. We don't have clear history what exactly they were. Chronic smoker, recently abstinent. History of cough with intermittent expectoration but no fever. He presented to my outpatient with generalized weakness, worsening of difficulty in walking and getting up from recumbency. Off glycoside, the blood sugar has gone up. BP is high. Intermittent cough but still afebrile. Chest scattered rhonchi. Vague costal pain while coughing. This was the clinical picture of the patient. Any thoughts? So you have a diabetic, you have neuromuscular weakness, then weight loss, diarrhea, constipation, depression,
smoker also.
He is a smoker also. Hmm? Hypo? Hypothyroid. Face is puffy, but it was not. He was not pale.
Worried about the steroid usage.
Steroid. He looks Cushingoid. Cushingoid, na? This was his onychomycosis. Severe onychomycosis. So what do you see? Striae were there, but are they typical of Cushing's striae? What are typical Cushing's striae? Broad, purplish, with skin atrophy. So there were very subtle pointers, but still, because he was taking a lot of over-the-counter medications, I thought maybe we are dealing with iatrogenic, exogenous Cushing. These are the reports: fasting, BP high, cholesterol quite high, triglycerides quite high. Then I got his cortisol. 8 a.m. 9 p.m. high, 10 p.m. also high, ACTH at 8 a.m. This was many years ago. We didn't have 24-hour free cortisol with us at that time. So he was not suppressed with the overnight, and even a high dose was not suppressed. So, high dose not suppressed. This was quite a big left adrenal adenoma. It was a big tumor, but the surgeon operated. It turned out to be an adenoma only. In addition, because he had cough and all, this was that adrenal adenoma. This was a CT chest, which showed a thick walled cavity, and AFB was positive. It was an open case of pulmonary tuberculosis. So diseases unfold their diagnosis in casual parenthesis. This was a quote of William Trotter. So a patient going to different specialties and each one looking through their narrow window. One diagnosing as depression, the other as proximal weakness, third diabetes, fourth neuropathy, and then it turns out that this is a fit case for Occam razor. Everything can be explained by one disease. Diabetes, proximal muscle weakness, depression, plethoric phase, raised suspicion of hypercortisolism. Onychomycosis, pulmonary TB, known complications of hypercortisolism. History of OTC made suspicion of iatrogenic Cushing, but documentation of ACTH independent and endogenous hypercortisolism due to adrenal adenoma, and adrenalectomy was reversed most of his problems. DM now well controlled only with metformin 500 mg twice a day. The patient was very grateful. So sometimes such things are very rewarding when you can fit everything into one diagnosis, and Occam's razor came in very handy in this patient. Now we go to case Finney 2, a 38-year-old male businessman, known type 2 diabetes of 3 years duration, well controlled teeth, recently on work chase, presented with obtended sensoria, like he was drowsy last 24 hours. On detailed history, there was polyuria and polydipsia last 48 to 72 hours, and dry cough last 2 weeks, back pains and generalized aches last 3 to 4 months, treated by an orthopedic surgeon with some injections 2 weeks ago. No fever. He looked clinically dehydrated, drowsy but arousable, no focal deficits. Neck was supple. He was quite well till recently, except for the back pain that was diagnosed as lumbar spondylitis. So what are your clinical thoughts at this stage of the? You have been presented with some initial information. So based on this data, what are your thoughts? Diabetes, polyuria polydipsia, altered sensorium, back pain.
Quite straightforward.
Hypernatremia.
Huh?
Hypernatremia.
Why are you worried? So you have somebody with diabetes.
Diabetes, polyuria polydipsia, admitted
It's
as
also
altered
even a
sensorium.
diabetes patient, you don't know what you
Uncontrolled HHS.
Either DKA or hyperosmolar state you will suspect. DKA or hyperosmolar state. And some injections has been given, we don't know what it could be. An orthopedic surgeon giving injection for back pain. So you will think of steroid and that has precipitated. So good thoughts. But then subsequently, no ketonuria, no acidosis. Plasma glucose at admission was 280. Sodium 138, potassium 4.2, BUN 52, creatinine 2.6. His creatinine 2 months ago was only 0.9 and CBCs were normal. So now what is your impression? Why not hyperglycemic emergency as an for a cause of altered sensorium? No. For altered sensorium in a hyperglycemic crisis, why does it occur? Osmolar. So with this 280 blood glucose, do you expect him to be hyperosmolar? No. So you have to look for alternative possibilities. So why the creatinine has gone up within 2 months from 0.9 to 2.6?
Dietary injections.
Dietary injections. Yes, NSAIDs is one possibility. And somebody else said something else, some other.
Calcium.
You wanted calcium? Yeah, good.
Yes.
As endocrinologist, you will immediately. That's very good. Because initially, when the physicians were looking at it, that didn't come to the mind, but then this was the X-ray. What do you see in this X-ray? Bilateral hilar prominence. So you narrow down your possibility. By the time the blood reports are already, and HRCT has been done, bilateral, paratracheal, hilar, and a few peri-aortic lymphadenopathy. Calcium had already come by the time, 12.2, phosphorus 3.6, and 25-hydroxy was 162.
Oh. That injection was vitamin D.
Oh, okay. More common than steroids.
His PTH is 8, that is suppressed, so non-PTH mediated hypercalcemia. But in sarcoid, 25-hydroxy D levels are 125 we have done. That was done later, but 25-hydroxy came first, which was high. So 25-hydroxy high should not be in a sarcoid. It's an exogenous vitamin D overdose. So sarcoidosis with hypercalcemia aggravated by iatrogenic vitamin D toxicity. This was an acute hypercalcemic crisis with acute kidney injury and metabolic encephalopathy. So there are many good learning points from this case. 2 exceptions for Occam's razor in this patient. Hyperglycemia was not the cause of encephalopathy in this patient of diabetes. He didn't have DKA hyperosmolar state. It was hypercalcemia. Hypercalcemia had more than one etiology in this patient: sarcoidosis and iatrogenic vitamin D overdose. So most of the time our assumptions may be right, but many times our assumptions may be wrong also, and we have to look for alternate possibilities. If you close our mind to one possibility and then stop, this is called premature closure. This is one of the cognitive errors I'll discuss subsequently. And the other thing which they call it is search satisficing. That is, you stop searching for further etiologies once you have arrived at one particular diagnosis. In this patient, if we had not looked for further possibilities, we may have just thought that it is only sarcoidosis, but actually it was iatrogenic vitamin D overdose also. So correlation of different points in history, examination, labs to need a cogent diagnosis. That was the key in this patient. Encephalopathy, non-oliguric AKI and hyaluronadenopathy with hypercalcemia, a granulomatous disorder like sarcoidosis, history of injections and elevated levels of both 25-hydroxy and 125, dual etiology of hypercalcemia. The relatives later brought injection, it was injection arachital given by orthopedic. We had given 6 lakh units, 2 injections within a week, which was probably detrimental because sarcoidosis is it's called a vitamin D hypersensitive state. They already have the ammunition to generate more 125 and you are providing more fodder for that ammunition. So what are the various reasons why clinicians do errors in diagnosis? The explanations given by clinicians, this is a beautiful article in BMJ, it never crossed my mind. I paid too much attention to one finding, especially lab results. I did not listen enough to patient story. I was in too much of a hurry, I didn't know enough about the disease. I let the consultant or specialist convince me. I didn't reassess the situation when things didn't fit. The patient had too many problems at once. I was overly influenced by a similar case in the past. I failed to convince the patient to have further investigations and I was in denial of an upsetting diagnosis. Most of the time, these cognitive errors run through the back of the mind and we err because of this. In fact, there are 30 cognitive biases described in clinical medicine by this beautiful article. You just note down this article, you can read this. It's an excellent article where each of these errors has been described with examples. Some are mutually interdependent. I'll show the last slide where all the references are quoted. This person is an authority on cognitive clinician cognitive reasoning. He has written several articles. So the chief cognitive errors only we will go through because it's very difficult to go through everything. Most importantly, availability heuristic. That is tendency to diagnose by recall of past experience rather than on the basis of prevalence and probability. So for this, how to avoid? You revisit statistics and prevalence of the problem. The second important is what is called anchoring heuristic. That is, you are anchored or you have stuck on to one particular impression, which was your initial impression. Tendency to fixate on the first symptom or signs on lab results. And many times don't think beyond that. So how to avoid that? Think beyond the most favored, reconsider in light of new data or change in course of illness. Our clinical encounters are always dynamic. Never close any encounter by not paying importance to further things which emerge. Every day in the ward when patients are admitted, you may get some new report or the patient's relative may bring some new record from the past medical history. Premature closure is another thing which I told you, acceptance of a diagnosis before it has been fully verified. So reconsider the case when refreshed and less distracted. So whenever you are in a busy outpatient or after a tired day in the emergency, always revisit the patient when you are more relaxed and consider extremes or red flags. What is the diagnosis I don't want to miss? This is another beautiful article. This was published in Lancet 1949 and it was readapted and published for relevance to modern medicine in NEJM last year. 7 sins of medicine. Obscurity, that is lack of clarity. Cruelty, mental and physical, that is over-investigation has been listed as a form of cruelty. Bad manners, over-specialization, love of the rare, what is called spanophilia. Common stupidity. Now we talk of artificial intelligence, but here they talk of common stupidity, that is mechanical and mindless following of protocols or therapeutic automatism. Remember, this was 1949. That time itself they started talking about following blind protocols. And sloth is reluctance to spend time in detailed history and physical examination. So these are the 7 sins of medicine. And here he writes, I have known an eye surgeon after seeing a case of retinitis pigmentosa write in the notes, this might be Lawrence Moon-Middle syndrome. Is there any evidence of polydactyly? For an ophthalmologist to feel himself incapable of counting fingers is surely the limit of over-specialization. And if nothing is done to stop this tendency, we shall have one physician who specializes in first ultrasound and the other in the second. This was in 1949. I don't know if he was alive today what he will say. So I am very happy to see that this is a mixed crowd of general physicians and different subspecialists, because there is nothing called a specialist and a primary general internist. They are mutually interdependable, and within you, every specialist should have a general internist also, and we should reawaken them from time to time. Every doctor should be jack of all and master of one, if at all you want to specialize. Physical examination is a necessary ritual. I don't know, many of you must have gone through the video of Professor Abraham Verghese, where he talks about this, that touching a patient, auscultating, percussing, more than giving you the physical findings, it's a form of a sacred ritual which creates a bond between you and the patient. And many a time it gives you a good diagnosis also. He laments about how a case of CA breast was missed in one of the biggest hospitals of US because nobody had touched the patient. They were just going through all the protocol of investigations. Just like Dr. Kannan mentioned about that mitral regurgitation murmur. So I had an experience like this with a thin young lady, severe acne and hirsutism, referred from, actually the patient was in Mumbai and later came to Chandigarh for polycystic ovarian disease. But from a distance you could make out that she is very lean, tall, and when I auscultated, I found that there was a severe aortic regurgitation murmur. And the precordium was so tumultuous. So aortic aneurysm, impending rupture. Echo was done and immediately the patient was sent for emergency surgery. The patient was already on oral contraceptives for a polycystic ovary which was stopped. The parents were devastated. They had come for some other purpose and a new disease was diagnosed. But then it was important because a Marfan syndrome with complications in a lean polycystic ovarian syndrome patient, we could not have continued the oral contraceptive in a patient with impending rupture of an aortic aneurysm. So many a time your physical examination will be rewarding. This is case Vinaya 3, a 30-year-old male farmer seen by a GP for high lipid levels, total cholesterol 280, triglyceride 180, LDL was 210, started on atorvastatin. He also complained of generalized aches and pains and muscle stiffness, so he went back to the GP. So as usual, once you start on statin and then complain of muscle pain, they did a CPK which was normal, which was slightly high. Dyspepsia and bloating, so went to a GE. So this is the bane of modern medicine. The GE did LFT, SGOT was 96, SGPT was 84. So he said it could be fatty liver or it could be statin-induced transaminitis. And this was the patient. Frank hypothyroid. The patient's voice was croaky from a distance. And this patient had already gone to several outpatients, initially treated for lipids and then for liver function abnormalities. The myxedematous look is quite clear. This was the, somehow, I don't know how in this patient with so many investigations done, usually nowadays the labs do thyroid function tests, but in this patient thyroid function tests were missed and this was the TFT done later. So error due to undue focus on individual lab reports without looking at the total picture. Overlooking physical examination. And primary hypothyroidism explains all his labs, hyperlipidemia, increased CPK, as well as liver enzymes, whereas it was attributed to the drugs in this patient. This is another short case Vinaya 4, very simple for an endocrine community. A 26-year-old NRI, T3 2.5, T4 14.2, TSH 1.5. Treating physician, technician thyroid scan, normal. And the patient had been on oral contraceptives for the last 3 years. So this often we get referrals from obs gynae in pregnancy for high total T3, total T4 with normal TSH. we have to explain to them that it is because of binding protein alteration. Free T3 and free T4 expectedly was normal. So in this patient, it was an unnecessary technetium thyroid scan, which was costly as well as a minor radiation exposure. The mental worry caused by mindless investigation. So that is why waste, worry, and the 7 sins of medicine, which was this is the article I referred to you, based on the Lancet article, what was written in 2020 by Rayleigh. He laments on this investigation after investigation for unnecessary purpose. So in this regard, I have to pay tribute to my examiner in MD, DM Endocrinology, Professor Bhandarkar. He was a teacher of teachers in KA Mumbai. He used to come to PJ as examiner, and he was my DM examiner. He said, as experts, it should be your mission to clinch almost all the complete diagnosis from history and physical examination and use minimum investigations to confirm it for optimal care. Your clinical acumen should benefit even poor patients who can't afford costly investigations and treatment. It was really an inspiring lesson to us at that time. So measures to avoid errors, these are some from my own experience, which I keep on telling my residents. Familiarity breeds not just contempt, but also complacency. When you are seeing the same patient over and over for the last 20 years, 30 years, you are not the right person to diagnose new diseases in them. Review patients whom you are seeing regularly to revisit history and lab tests. In this regard, my professor and former head endocrinology PJ, Professor Dash, unfortunately he is no more now, he used to insist that the case files will be swapped. At the end of the OPD, we all used to sit and have a post-OPD discussion where we will swap the case files, and the next OPD we will see the cases which were allotted to some other person, so we can pick up some new findings or go over some errors which have been done in the past. Be paranoid. Don't accept everything written in past medical records without verifying. As Dr. Kannan said, the Doppler done already normal report, but you are finding florid murmurs of the bruise of renal artery stenosis. So a clinician should always be paranoid. It's not that you are disrespecting your colleagues, but always don't accept everything written in past medical records. This will avoid the cognitive bias called diagnosis momentum and framing error. This is another important cognitive error. Whenever some case is already sent to the emergency as a known case of psychosis or MDP, any new organic illness also will be framed as a psychiatric disease, and the patient will receive a wrong treatment. So encourage trainees to present cases as they evolve, not with preformed diagnosis, a case of. Nowadays even patients come to you and say, what is your problem? PCOD. Then I बोल रही है आप problem क्या बताइए? Testosterone ज़्यादा है. Then I please tell me what is your problem? नहीं, my ovary is showing cyst. This is how they present cases. This is case when you 5. A 60-year-old female diagnosed hypothyroid in some other hospital 5 years ago. Periodic TSH monitoring, low TSH values, many less than 0.1, so they kept on reducing the doses. Clinical worsening, progressive asthenia, fatigue, anorexia. So I called the patient. Usually I ask every patient to bring all the past records, but unfortunately many of them nowadays they say 10 साल का पुराना record who will bring. So but I somehow insisted and got all the records. The pre-treatment TSH was like this, and the patient was always being treated as hypothyroid. It's written primarily hypothyroid, and the diagnosis is continuing. TSH was low, T3, T4 low, and because this patient was clinically also having features of hypocortisolism, and these reports are clear-cut suggestive of secondary hypothyroidism, that is central hypothyroid. I got a cortisol which is low. This was the patient. Axillary pubic hair absent. There was breast atrophy,